afternoon. My name is Laura Chatterton. I'm the nurse practitioner that's going to be performing the exam today on our patient. We're going to start with a general assessment of the patient's mental health, beginning with an observation of their level of consciousness, followed by an examination of their posture, body movements, and gait, looking also at their general hygiene, looking at their reactions to others and to their environment are also key indicators of good mental health. I'll examine their speech and language for rate, volume, fluency, and quantity of language. I will also take a look at their facial expression and affect, ask them what their mood is. Looking at their thought processes, content, and perceptions is equally important, as well as looking at their general fund of knowledge, their ability to apply and correctly use vocabulary, be able to engage in abstract thinking, as well as doing minimal calculations. A long-term and short-term memory assessment would also be part of this, as well as their ability to keep their attention and focus. And lastly, just in general, making sure they're alert and oriented. The physical examination of the head, eyes, ears, nose, and throat begins with an examination of the skull, looking for symmetry, size, shape, contour, and any depressions. As I palpate, you want to note there is one normal depression where the occipital and parietal lobes converge. That is an absolutely normal finding. Looking at the scalp, underneath the hair, I want to take a look to see if there's lesions, lumps, masses, parasites, or any sign of trauma or any general dryness. Hair, we look at the patterns of loss. We look at its texture and thickness as well. Facial examination begins with looking at the symmetry of the structures, looking for any involuntary movements or edema, any contours. The skin, we want to look at the color, the pigmentation, the texture, the thickness, looking at the distribution of hair and its thickness. And any noticeable lumps, bumps, scars, discolored patches, any signs of rashes or infections like impetigo or acne. When we have achieved a physical examination of all of those structures, we'll then palpate the temporal pulses. Once those are felt, we can move down to the temporal mandibular joint and ask the patient to open and close, looking for the articulation of those particular bones. That gives us an indication of their ability to engage in proper eating. Eye exam is next. I'm looking for symmetry of the structures associated with the eyes. I see that right now there's no drooping or ptosis of the eyelids. The palpebral fissures appear to be normal. The patient is able to open and close their eyes. Pulling down, I can see that their conjunctiva is nice and pink with no abnormalities. Checking the sclera or the color of the eyes, I pull down, ask the patient to look up, down, and side to side. This patient has nice white sclera, therefore indicating yet another normal finding. Using my pen light, I'm going to check the lens, the cornea, and the pupils. Looking for any opacities. By looking obliquely, I'm examining for any foreign bodies, the iris margin, and any concentric shadowing or shallowness, which might indicate a narrow lens glaucoma situation. Pupillary response is next. The direct method is to shine a light into the patient's eye, looking for the pupil to respond equally round and reactive to the light, which they do. That would be a positive direct test. Consensual test is putting the pen light into one eye and looking for the pupillary response in the opposite eye. That would be a consensual test. Also, moving on, we would need to do a visual acuity test for our patient. I would have a Snellen chart hanging over my shoulder on the wall 20 feet away. We would cover one eye and ask the patient to read the smallest line that they're able to do. Depending on that score, we then move over to the other eye to determine what their level is. And the Snellen chart renders decisions of 20/20, 20/40, or 2200, for instance. The upper number indicates the distance that the patient is from the chart. The lower number indicates the distance at which a normal person can actually see that. If the patient for any reason is having trouble reading or is over the age of 45, you can give them a cart that they hold 14 inches away from their head. If they're able to read, that's good. If they're not, they may need to be seen by an ophthalmologist for further testing. Next, we are going to do the visual fields, which are going to test for peripheral vision. I'm going to put fingers in the air, waving them lateral to the patient's ears, and as I move forward, they tell me when they can see them. And then I move my hands about 2 feet apart and come forward and do the same type of testing. This allows me to check the 4 quadrants of both eyes for visual perception. Next, we're going to do intraocular movements or muscles. Holding out a finger, we're going to engage in the 6 cardinal views of gaze with the patient's head remaining fixed. We're going to go out, up, and down in both eyes for testing. Using my finger once again for convergence, I'm going to bring my finger forward to about 5 to 15 centimeters. If the patient's eyes kind of look like they're crossing or coming to the medial aspect, that is a test of convergence. A test of accommodation is having the patient stare at my finger, then an object on the wall, and then back to my finger. When the patient looks at my finger, the pupils should constrict. When they look away at the object on the wall, the eyes should actually dilate. That is known as accommodation. Next, I'm going to engage in a fundoscopic examination using the ophthalmoscope. I'm going to look at the patient's right eye with my right eye with my hand on the scope at about a 15-degree angle with the patient looking forward. I'm going to look for the red reflex. Once I know that, I know I'm at the area I need to be into to look at the structures of the pupil. Moving in with my thumb above their eyebrow to prevent any damage. I'm going to look inside the pupil for the optic disc. The vasculature, I'm going to also look in for the physiological cup and look for any abnormalities. Moving a little bit medial, I'm going to look for the macula and the ovea. If I were to notice any AV nicking or any copper wiring, I'm going to know that this patient suffers from chronic hypertension. If I see any cotton wooling, I know I'm going to be looking at a patient who has diabetic or macular retinopathy. And this all looks very good. The optic disc should be a pearly pink to orange color, and the physiological disc should be about half the size of the optic disc. I'm also going to check the structures for clarity as well and sharpness of the margins. That is why it's so important for the operator of the ophthalmic scope to be able to move their lenses to accommodate for their eyes. Next, I'm going to move on to the ears, looking physically at the outer structures of the ear, feeling and palpating the helix, the antihelix, the lobes, and the tragus, feeling the mastoids. There's no obvious redness, drainage, or exudate coming out, no swelling. Using a quick tug test just to make sure there's no pain with the otoscope going in before I even look. I'm going to hold the otoscope and go forward and down, noticing that the ear canal is a nice light pink. There's no signs of any trauma, no bleeding, no indications of any lesions. Looking down at the tympanic membrane, I see one that is pearly white. It is notable for the long and short processes of the malleus, also the udum. The cone of light is present. The pars tensa and pars flaccida are also present as well. So that ear looks good. If the tympanic membrane for any reason was red, bulging, or perforated, we could potentially have a situation where there would be some kind of constriction or some kind of infection rather. And notice when I did the exam, you want to pull the ear up and back in order to access the canal properly. Next, I'm going to do the whisper test, occluding one ear by pushing in the tragus. I'm going to whisper in 3 numbers and letters. Testing the patient's relative hearing levels. And you would repeat that on the other ear as well. Our next test is going to be the Weber test, or test of lateralization, striking the tuning fork and placing it midline on the patient's head. I want to know if he can hear in both ears. That would be a normal test. If not, if he heard it in the impaired ear, then that's a conductive hearing loss. If he heard it in the good ear, that's a sensory neuro problem. The Rene test, striking the tuning fork and placing it On the mastoid, he has to let me know when he can no longer hear it. When he can no longer hear it, then I place it on the outer aspect of the ear for air conduction. Air conduction of the vibration should be twice as long as that of bone. And in our patient, again, we have all positive findings, or all rather normal findings. Nose is next. I want to physically look at the bridge, the dorsum, the anterior nares, and the vestibules. Using my otoscope, once again, I go up and I look at the inferior and middle turbinates. I look at the nasal passage, the narrow passage between those and the septum. I look at the septum for color, for drainage, for any polyps, any other discharge or bloody areas that seem abnormal. In this case, none of those structures are present. Everything looks very good. Test the breathing by just pushing in on one side, asking them to breathe in on the other. Everything here seems to be well. Mouth is next. The external structures, the color is good. No herpetic lesions, lumps, bumps, masses, no cuts, and generally dry. Looking inside the patient's mouth, I see the oral mucosa is nice and pink and moist. I can look at and notice the parotid and submandibular salivary glands. I'm looking at the teeth, the gingival margins, the interdental papillae. I'm looking at the color of the teeth, noticing any that are missing, broken, or appear to be infected. I ask the patient to stick his tongue out and say, ah. Oh. The uvula is midline. The palatine pillars are present, and the tonsils are absent in this patient who had them removed. And again, looking at the roof of the mouth, hard and soft palates. With the patient sticking their tongue out, I look to make sure it's midline. I look at the dorsal papillae, which are present, and no issues with there. There's no white patches, there's no nodules, and no other abnormal findings. With a gloved hand, I'm going to go in and feel for any induration. On the oral mucosa, I'm also going to palpate those salivary glands. I'm going to ask the patient to stick their tongue out, and I'm going to palpate the lateral aspects of their tongue. Stick your tongue out, please. And again, all of this appears very normal. No signs of infection, no white patches, no nodules, and no signs of carcinoma. After we do the mouth and the tongue, we want to look at the neck. With the neck, we want to look for symmetry. Everything appears to be lined up. The trachea is midline. I'm going to move to the lymph nodes, starting with the pre-auricular, doing a gentle massage with 2 fingers. I go to the post-auricular, the occipital, the tonsillary, the submandibular, submental. And again, any lymph nodes, they should be pea-sized, soft, equal and consistent, no pain upon palpation. Moving down to the anterior cervical and then the posterior cervical. All of that looks good. We're going to look for the deep cervical chain, which again is difficult to palpate because they are in fact deep. Moving on to the supraclavicular and the intraventricular or intraclavicular. Intra meaning below, supra meaning above. No noticeable findings here. Again, we want to check for the size, consistency, the relative mobility, and any pain when we're checking for those nodules. Next, we want to check, I'm going to tip your head back up. We're going to be looking for structures associated in the neck with the thyroid. We have thyroid cartilage. We have the cricoid cartilage. And then right below all of that, we're going to have the thyroid gland. You can palpate it anteriorly or posteriorly by noting your index fingers below, asking the patient to swallow. And again, with the thyroid, we want to look for any nodules. We want to look for any obvious goiter, which would be an enlarged thyroid. We want to look for any bumps or any tenderness. Fortunately, our patient is relatively healthy and normal, and there were no negative findings for this exam. Thank you for watching my video, and have a great day.